I want to invite our morning keynote speakers up to join us. Representative Paul Seaton from Homer, Representative David Guttenberg from Fairbanks, and Karen Perdue from all over Alaska, but currently Fairbanks. Come on up, let's give them a round of applause.
Where the ferns.
Yeah, right. It's not between two ferns, but it is between two plastic trees. So we have them on either side. Thank you very much for coming and for being here. And you three know, but you all may not know that I never I never pre-send questions. I usually don't even tell them what we're going to be talking about other than the title and a general framework, because I think that it's very important to have sort of an authentic, kind of real-world conversation, the kind that you might have over dinner with a lot of wine, but we don't have any wine here today for very good reason, given the hour. Karen, let me start with you. You've been the head of the Hospital and Nursing Home Association, ASHNA. You've run the Department of Health and Social Services under a previous governor. You've had a lot of different roles to play, including now in Fairbanks, being involved with the hospital transition. How is this time different? And the challenges today, how is it different from all of these other periods in your career? And what do you make of it?
Well, I was actually thinking that it's really not that different. I was telling Representative Guttenberg I was cleaning my garage, and I was going through paper reports, when we used to have paper reports. I don't know if you remember that, but and I served on a task force, a health task force for the state in 1993. And I wish I had brought the document, but the headline of the report was, "Crisis, healthcare costs are out of control." And estimated that we would be spending $5 billion in total spend. The total spend for healthcare in that report was $1.5 billion. Total spend today, I think, is about 7 or 8. And estimated we would be about 5 in 2013. So it was pretty close. And it called for a single payer system. It was an actual legislative report. Of course, it didn't really see the light of day after that. So I was thinking that we've been wrestling with these issues for a really long time.
Yeah. The more they change, the more they stay the same, huh?
Yeah.
Yeah. Representative Seaton, you chair the Health and Social Services Committee in the House. I told you before that in as far as I can be objective, and I try to be, it seems to me that SB 74, the Medicaid Transformation Bill, was the biggest reform bill to have passed the Alaska legislature, maybe to have ever been even considered in the Alaska legislature. It came out of the Senate, came through many committees, including Finance. I think you and your colleagues, like Representative Guttenberg, deserve applause for shepherding a very complicated bill through. What is it like working on health policy today, given all of the craziness, generally speaking, from both parties around the politics and the language and some call it enthusiasm, some might call it vitriol. How do you get a bill like that passed?
Well, it's difficult, and of course we had a companion bill in the House that we worked on, had tons of hearings on, and then we coordinated with the Senate on their bill so that we didn't have to bring that to 2 committees. Mm-hmm. So the changes that we had, we pretty much got incorporated in the bill. Mm-hmm. They modified the bill on the Senate side so that those were already in when it came to the House. So mm-hmm. that's some of the politics of how you can get things done instead of waiting till the end and then having huge reversals in conference committees that are trying to revise those issues. So I think that was very helpful because we actually did coordinate between the House and the Senate on many of those provisions.
What was your caucus? What were the caucus conversations like with some of your Republican and conservative colleagues when the question of Medicaid reform was discussed privately.
Well, Medicaid reform wasn't objectionable to most people. Most people wanted Medicaid reform. Medicaid expansion, on the other hand, was a very different conversation. And the politics of that was very difficult. And it was very interesting because it never came to the floor for a vote on Medicaid expansion in either the House or the Senate because it would have passed either body. So there was politics involved in not wanting that to come to the floor in either body. But, you know, we got it through the governor's expansion, and that's held up in court. But we did need the Medicaid reform because the payments and the way we've structured it with the allowable benefits were critical that we need to change. I mean, when you have the most expensive healthcare system in the nation and you have some not the best outcomes, then you have a real problem that you have to fix. And so the system had not fixed itself internally. You know, that's one of the ideas of, well, shouldn't doctors and hospitals just be allowed to fix it on their own? Well, we have the system we have because those standards of care have been in place from doctors and hospitals and insurance companies. And we're no longer able to afford that. And so there has to be changes. I have always been trying to get the medical communities to come together with the legislature to coordinate those reforms, or the insurance companies to come together to coordinate those reforms instead of those reforms being imposed. And so, you know, that's where we are as far as politics goes. I'm happy to see that people are coming together. I'm the House representative on the statewide opioid task force, which is a huge conglomeration of people working together to try to solve a problem that's been created in the medical community. And, you know, we can talk about that later, but...
I should note also that I believe, and we talked about this moments ago too, that I believe you've been at every one of these conferences, or at least 5 of the 6, and so thank you for being here. And I just think it's indicative of your interest in having a conversation where it has not always been embraced, this notion of talking about healthcare policy. Representative Guttenberg, you said something interesting last night that I'd like you to expand on. And I'll frame it similarly to this question to Representative Seaton, which is, you know, what was it like shepherding some of this legislation through SB 74, the 91, the criminal public safety reform bill, criminal justice reform bill, when these were largely Republican-sponsored bills, but not terribly out of line with what many Democrats in the legislature would have probably wanted to see had they written the bill.
Yeah, it was interesting. Sitting on finance, where we hear almost everything that has a dollar figure attached to it, you don't pay a lot of attention until it gets to you. You know, you're watching it in the background, you're hearing your colleagues talk about it, what's it doing, what do they like, what amendments were tried. You know, the House is cynical about everything comes over from the Senate, just like the Senate is critical of everything coming over to the House. It's kind of the nature of the beast. And then the reform bill landed in finance, and you could see the schedule was set up for a lot of hearings. And I was walking through it and paying attention and watching. And what I said last night was I had to muffle my enthusiasm for the bill because I didn't want people to see that I was so enthusiastic about it. Because there were sections about it I certainly liked, and I've told people, well, I could have written this bill. These are things that I like. There are, in the language section in the back, I think it's section 55, the bill calls for significant studies to determine outcomes that are legitimate questions that should be asked on the direction that I think the state should be doing. But I know other people had other opinions on where they thought those answers would be to those questions. But I'm advocating a single-payer system, and you know, in order to get there, you have to understand what the nature of the beast is, and those questions were in there. So watching that happen and roll out, and watching the senators come and talk about their bill and defend the sections and what they want to accomplish. And it's like, well, I like this too. So, you know, we all play our cards kind of close in the legislature, and you know, because you might sign on as a co-sponsor of the bill one day and hate it the next. Yeah. You know, because it changes and it changes something. But I was a little enthusiastic about the direction it was taking because it was legitimate. It wasn't a partisan aspect of getting a handle around healthcare, which had a predetermined outcome, which is what I liked. Yeah. Let's figure out the real answers to real situations and take those from someplace and go.
So let me ask you sort of a philosophical question that I think Representative Seaton was getting to, which is, do we need more, does the healthcare system need much more regulatory oversight in order to be the best system it can be, to be maybe effective at expending resources? Do we need more regulatory oversight, or do we think that now's a good time to sit back and let the market, the healthcare marketplace, sort itself out a little more?
Well, I have a little cynicism when you talk about a market, whether its ability to function and how free market it is. But the nature of the question about regulatory reform, or is there enough? I think the first question you have to ask is, are we doing it right? You know, we don't need more regulation if we're fixing something that's broken. You know, if we need to come back a couple of steps and correct a course, well, we can get rid of a whole lot of regulation and simplify it so that everybody's on the same page. And I think that's really the big problem that we're facing. And, you know, the goal of State of Reform here, I give you a plug, is to find that common ground where things work better, where things are easier, where it just works naturally for outcomes and how we measure the matrix of healthcare. And of course, the most important thing is delivery to the patient and their outcomes. So we don't need more if it's wrong.
Yeah. Very savvy politician just figured out how to get in our highlight film. Good job. Karen, let me ask you sort of a similar kind of question, because I think it's sort of fundamental to this notion of health policy. You know, do we need more activism from state government? And since we have legislators here rather than agency folks, do we need more activism from the legislature to address some of these challenges in Alaska healthcare?
Well, this is a perfect question for me since I've spent 25 years in state government, so I'm pretty qualified to comment, and the answer probably is no, with some exceptions. My belief is that the state, and my experience in being in the state as Commissioner of Health and other roles, is that the state is unable to look at the whole market, with the exception perhaps of the Division of Insurance and some of their activities. They're mostly focused on how they can save the state money. So I continue to worry about structures like health authorities and other things like broad databases and so on that really give the tools to government to really focus and regulate the whole industry based on saving money for the state government, and thereby by transferring costs to the private sector. And I've seen it happen. I've done it myself. So I do worry about that. I do think there are things the state can do and is doing now, and I do applaud the bills that passed this last year. They're really landmark, the legislation on Medicaid. However, most of the things in the bill probably the department would have done if they had the resources and the permission anyway, without the legislation, you know. So I think that state government has a great role for convening. I think we lost several years during the ObamaCare rollout, where we had such political division that we really weren't able to discuss healthcare very well in our state. So I think the state government has a good role in convening. They have a good role in laying out policy questions. But in terms of regulating the market, I don't think that's where they should be.
Yeah, interesting. So a general antagonism to the idea of being, this isn't really what you said, but it's sort of what I heard, so I want to make sure you can clarify. A general antagonism to an over focus on cost at the state level?
to a focus on costs as it relates to state government, because there's so much pressure, especially now, on administrators to, bring in things under the bottom line, and thereby, as we all know in healthcare, transferring costs to another sector. And that's an overgeneralization, because there are some really excellent things like the emergency room project that's going on and other things. But I think we need to be careful in taking a private sector industry and really thinking that it should be regulated by the state.
Representative Seaton, how would you respond to that? You were making in some ways a little bit of a different argument, sort of a counter argument earlier in your comments that, if left to their own devices, the healthcare sector becomes the most expensive system in the most expensive country on the planet.
It has. It's demonstrated that that's where we are in healthcare. And that revolves around the incentives and what we measure. The opioid addiction problem that is pervasive and is going to cost us billions of dollars was caused by the change for measuring and incentivizing pain management. Pain management becomes one of the criteria that you're going to be measured on as a successful business. You're going to do it well, and Big Pharma will give you the products to do it. And we have overprescriptions. We are higher than the national average. In some places in our state, we're double the national average for seniors in the percentage of prescriptions that are issued to seniors under Part D medication, or Part D Medicare for opioids. Almost 9% of all prescriptions on the Kenai Peninsula for Medicare Part D are for opioid pain.
Say that again, 90%?
Almost 9%.
9%. Okay.
Nationwide, it's under 5. Statewide, it's over 5. So, the system is there. I cannot be in the legislature and say, give us a blank check, when the blank check that we've been giving through has developed the system we have. So there have to be changes. And I was just at a National Conference of State Legislatures, National Conference of Health Committee Chairs, and we found that in Maine, they have gone in and they've said, we're going to pay for EpiPens, Narcan, but we're only going to do generics because there's one of those that costs $4,000. And if there's no detriment for a prescriber for doing this thing that'll talk to you and tell you take the top off and stick it in your, and it's $4,500, I think, per unit. And, those are just outrageous things, but there's no restriction on the providers from using whatever they like. And so we can't afford those things. So there's going to have to be changes.
So, Representative Guttenberg, you're on the Finance Committee in the House. I think we have this sort of manifestation here of sometimes a common challenge of, the folks in the healthcare system know how the system works, let them run it, versus, look, we can't keep covering the costs of these, and somewhere in between is probably the compromise and pathway forward. How is it on the House Finance Committee today under this governor versus previous administrations? What does that role of leadership get, to some of Karen's comments about the nature of politics? What is the role of leadership as you experience on health policy on the House Finance Committee?
Well, how is this administration different? Is that kind of the question? But I'll tell you, Commissioner Val Davidson has done an amazing job of bringing together a team that has the answers, that has clarity, that has the ability to put things on the table that are believable and to defend them. There's an old axiom: once you can fake sincerity, you have politics made. But they do a great job. They lay it out and defend it well, and stick with the points that need to be addressed. And I've been very impressed with rolling it out. I mean, expansion and reform are difficult things. Both of those are monster issues in the legislature. They're very divisive, but they kept it simple, they kept it clear, and they did an amazing job. They had all the answers, and if they presented the people to us that had the answers, I was very impressed, and very impressed with their ability to just stand there and take the onslaught, because once you kind of start knuckling under, it doesn't end. It's piling on, happens, whatever the issue. They did a really good job, and you know, it was a group of people that we could trust when we move on to other legislation. When we moved on to other things, we know those people, we trusted them, they did a good job, we had all the answers. So this administration has done an excellent job in presenting health care to the legislature.
You know, one of the more technical bills that passed the legislature is related to a reinsurance product. I don't want to get into the details up here of actuaries, reinsurance details, but that legislation had as an apparent effect a lowering of the requested rates by health plans, particularly Premera, moving from annual rate increases in the 30s and 40s down to about 8 or 9%. That seems like, sure seems empirically like a good thing, right? Moving the cost trend down. On the other hand, there's a $55 million or thereabouts price tag from the collection of fees via the state to support that high-risk bill. Are there other solutions? That's a technical solution, but it still has a price tag on it. I'm wondering if there are solutions that you guys are hearing about in the legislature, if there are things that you're having stakeholders come to you with that maybe are technical in nature, maybe they have a price tag, but are they different and innovative compared to conversations in the past, or are they kind of the same things getting asked for over and over again? Either one of you can jump in.
Well, I think one of the big problems we have now is we don't have clear, measurable matrix in healthcare. You know, to compare the providers, to compare the regions and the hospitals, we don't have a public transparency of what exactly is one to another. You know, when you ask that question, I think you have to go back and ask the question of what is the cost, how are the costs created, what are the results from those costs, and comparing one hospital to the next. There's reasons, there's hospitals or clinics or whatever, every aspect of healthcare, and understanding and determining what the cost differentials are, to understand the different groups, the different regions. There needs to be more transparency and measurable matrix of all aspects of healthcare to put it on the table, to be able to look at it. You know, why is this more expensive here? Why is this more expensive there? Then as the state, and Karen says that, you know, just like the state has a different role because it's only looking at the state's bill, but that would, I don't think anybody else can do that. I mean, the industry could do that by itself if they wanted to. It's a tough call. Mm-hmm. But how do you measure the difference between what the state's paying for everything it does, whether it needs reinsurance or where it is or where the holes are? You know, we don't get those answers. We can't see those answers. It's a lot of things that are troubling to me, is getting the right data to come up with the right answer. You know, Paul's a fisherman, I'm a retired construction worker. We are expert in every one of your fields. Right? We make the decisions for you as far as the state goes. You know, and I need the numbers, I need good data, and I never get it, because this is a tough field to understand what it is, the difference between why is it this here and why is it that here. What's the delivery and what's the difference? There are, you know, being in Fairbanks with it, Fairbanks Memorial Hospital does a great job. It does a lot of different things that in other places are done by other people. So they built in a lot of those components into their billing. But to have the naked costs for what's delivered where, to make those decisions about what's the best thing to do, for me, that's the first step. Yeah. And getting there is really tough.
Can I just talk a little bit? Oh, sorry.
Well, I want to have
course.
Representative Seaton take a crack at this innovation question, then you can jump in after, Karen.
Sure, and really there's two things I think we can look at is will industry do it on its own? Since 2006, I believe, is when legislation got passed that allowed the department to do a care coordination system, a pilot project. Nothing happened. SB 74 and our House bill, we were mandating a requirement that they will do a pilot program. It's probably going to be Central Peninsula Hospital, global payment model, care coordination. We know that fee-for-service is going to go away because we can't afford to do it. But the question is, and at one time they were saying, we're just going to do this for the entire state. Well, we get big problems when you try and do too much, too soon, too quickly without enough data, without knowing what works and what doesn't. So there's mandates for that. The other thing is we need to look at the other side because that's only care. And sometimes we talk about health care as being only spending for sickness. And the other thing that I've been working on for quite a while is the other end of things and keeping people healthier. So I think that there is becoming more of a recognition that we shouldn't just be talking about sick care, we should be talking about health. And if any of you want to follow up the latest stuff on vitamin D, there's the largest clinical trial in the United States, got over 10,000 people doing that, and that's this little booklet out there on the desk that we have out front has all of their data on dosages and results and the 70% reduction in new cases of cancer and all those things. I don't want to get into specifics.
Well, I just was going to say, we host this in a lot of different markets, a lot of different states. I know a lot of people. I don't know anyone more passionate about vitamin D than you.
Well, and that's not the only thing. You'll also see out there the Department of Defense, the nutritional armor for the warfighter. They had expert panels go in and they said, we've got to immediately change our nutritional, our rations because they are having all these stress fractures and all, and they can cut those in half by just changing the ratio of omega-3, omega-6.
Yeah.
And that's expert panels. So there's two ways of addressing this. One is controlling costs for the service, and the other is not requiring the service to be formed
In the first place.
Right. And, it's one, if we're left to the device, we're just going to have to cut rates because we can't afford to pay the rates.
I want to come back to that framework because I think there's a lot there. Karen, I interrupted you. I want to give you an opportunity to respond.
I was just going to say that on the issue of Representative Seaton's, the way he framed it, I agree with it. And one of the most exciting things that I've seen in healthcare, in my experience, is the embracing of the quality agenda that's occurred. So the quality agenda at hospitals and nursing homes began with a regulatory approach, primarily Medicare, and Don Berwick's efforts to impose the triple aim. But I think pretty quickly, most individuals, clinical leaders in healthcare at the hospital level embraced the idea of using data to improve quality of care. And actually use the data themselves. Now, we have a ways to go on that. We talk a lot about that in Fairbanks at our hospital. We're aligned with our primary care clinic. So we have great plans in the future to work across our multi-specialty clinic, which is the largest in the state, and our acute inpatient and our long-term care and our palliative care and our hospice, and use those outcomes more broadly so that we do prevent people from unnecessarily using the healthcare system. And so I just want to say that there is a lot of data. Now, a lot of it is Medicare data, but outcome data is really welcomed as far as I can see. And if you can bring that to providers in ways that can reflect meaningfully on their experience, I have not seen much resistance to using that data. Now, who generates that data and how that generated is managed and controlled and used or used against them, that's all really important conversation, really important.
But generally speaking, the notion of transparency is talked about more than it is embraced, right? Generally speaking, things like an all-payer claims database or even a charge master transparency, much less a contracted rate, generally speaking, are not getting released or not supported.
If you talk to people about the steps, as I understand it, the steps to getting to full transparency and cost, you start with quality, because that's actually how providers, focus their effort. If you move right to cost and you don't really provide the system with the outcome data that's patient, that's quality, that's clinically driven, then you're really having a divisive conversation, in my opinion.
Well,
So,
let me ask you, Karen, as a system level thinker, and as you said, both in and out of state government. Governor Kitzhaber may make this argument later today. I've heard him make it in other settings, where he would say, look, we know what creates health. It's a little bit of the healthcare system. It's also things like good nutrition and sleep and social interactions and all of these other things, right? And we know that if you have adverse childhood experiences, those are often intergenerationally transferred from parent to child, so on and so forth. One of the things Alaska is really very strong at is thinking about care in a trauma-informed way and adverse childhood experiences. If those are the things that create health, should our healthcare dollar go to support those things? Or, he would question, should it keep doing what it's doing, which is going to pay for medical care delivery, which is not all of health, it's a part of health. What, the implication to the answer is that maybe legislators should change the way they ask the department to fund through Medicaid health, or the implication is actually no, we need to keep supporting the healthcare delivery system, at least in terms of how Governor Kitzhaber would argue. What do you think about this notion of spending more healthcare dollars on health?
of course, absolutely. And the question is the transition. How do you get there? And is it a good outcome for someone to come to the emergency room over 100 times in a year? Absolutely not. Yeah. Not only that, the person isn't getting the continuity and quality of care that they need to get better. So yes, we should be transitioning, and one way to look at that is, as I understand what they've done in Oregon, is they allow incentives for the money to move upstream. That there's actually people in the system seeing patients can feel good about case management, moving to putting some of the healthcare dollar there.
Mm-hmm. Let me just stick with you for a second, Karen, because I think in Fairbanks you have a unique conversation happening now related to the hospital and who will administer and own that, and it's going to continue to be owned by the community. It's going to now newly be administered also by the community. And you're sort of a closed environment up there. There's not a lot of leakage. People don't drive 10 minutes and go to a different hospital, right?
Yeah.
Is there maybe fill us in on the conversation that's taking place in Fairbanks about how that community should be supporting health? Well,
we took a big leap. As you may know, we had a long association with Banner Health out of Phoenix. And it just became clear over time that our culture and the Banner culture were not really aligned. There was a lot of matrix management. So, for instance, the clinical primary care clinic and the hospital and the CFOs and the long-term care people all reported to somebody different. And we had a strong board, but the board was really focused on, and the foundation of the community, this is not a government entity, owns the physical assets of the hospital. So we've been leasing that, but not really understanding what the quality agenda was that our people in the facilities were really striving for. So I think we came to the realization that to be a real community-owned system, we really need to embrace and understand the services as well. It's a big move, and it might not be forever that we're independent, but it's causing us to really look at our assets, look at our strategic direction, and direct for our own community where the gaps are, and to try to have the various entities that we do manage, and including the independent physicians that we also work with, to see if we can't get better outcomes.
Yeah.
So it's a little general, but there's a lot of details. I can tell you January 1 is coming soon.
Yeah. Representative Seaton, I want to see if you can offer us a window into the functioning of government in your oversight capacity of the department. And specifically, I think there are a lot of folks, I think Commissioner Davidson is one of them, that would like to do some of these things, pay for health instead of paying for health care. But the department has capacity issues. It can't, it's doing everything it can to be doing what it is now. And you know, for many months, years, it had a hard time even paying claims to Medicaid providers. What is that like, looking at the department, knowing that the leadership is there, but we just can't make the wheels of government move in a way, either for lack of resources or lack of something else? I'm sure there's a long list. You know, it must be frustrating to say we have a common vision, but we just can't make the wheels turn. Is it?
Well, that's a hard question for me to answer because I'm not in the department.
Yeah.
You know, the department comes before us and we talk with them and they explain to us, and they're really good about giving us information when we ask questions and how that goes. But you know, it's kind of back to this other question of how the healthcare system work. I mean, it can't be that we just say, okay, you're going to do quality, and by the way, you're going to lose all the money that the services you would have provided. You're going to lose that. I mean, there's got to be, you get what you incentivize and you get what you measure. So if you don't measure the quality of health, and you don't measure, and you don't incentivize health, which will save you costs at the end. If you don't incentivize that for some payment, you have to integrate those two things, because otherwise you're not going to get it. I mean, if you incentivize fee for service, you're going to get fee for service. If you incentivize the preventive health, primary health, we haven't even talked about the parity that's required under the Affordable Care Act, and we're sitting here trying, you know, in '74 and all, we were trying to figure out how do we at all get there when we have a system that doesn't have near enough professionals to provide the care that's required under parity of care.
Yeah.
So I'm not answering your question, but I think that it's important that we recognize that we have to change the system, and the legislature has to do that. And the legislature has to authorize those changes, but we've now required that there be a coordination of care, at least one project, and possibly two.
So, Representative Guttenberg, let me ask you a very complicated technical question. I see, according to one report, that Hillary Clinton is losing by 3 points in the state of Alaska. Is she going to win?
In the United States,
In the state of Alaska.
State of Alaska?
Is it possible that a Republican could lose this state for president?
Well, when you're talking about elections, anything is possible. Anything is possible.
Yeah.
The history, the last time a Democrat took Alaska was Johnson. So in the nature of things, it's as close as it is going to tell you what's going on.
How is the fiscal challenges, how are the fiscal challenges, and a perception, maybe not the only perception, but a perception that the legislature has not dealt with them adequately through multiple special sessions. How is that impacting legislative races? Are you hearing about it when you go back home? Do you think that that will have impacts for next year's legislative majorities?
Oh yeah. Well, for everything, the public never thinks we do anything, or if we're doing something, it's too much, right? I mean, just like healthcare, when we started to do reform, there's always a segment that has a problem with what we're doing or not doing. Well, the outcome of this next election and how it affects the makeup of the legislature, there's going to be a lot of freshmen coming in this year, and there's a huge learning curve. Wherever organization they sit down is, I think there's already at least 8 freshmen coming in the House. I think there's a couple more. Some races might change. That's a lot. I came in with Paul. There were 10 of us, and that's big. You know, you had the freshmen and you had the the sophomores, the people that have been there 1 year, the first thing we do is we teach them where the bathroom is, and then there's just a giant learning curve for what we do, because we do so much, and freshmen don't know, haven't staked out their territory. You come into the legislature and you think you're there to do something, and you find out you want to do something else, and that's a giant shift on learning curve. So whatever the outcome of it, we're going to have a lot of freshmen coming in, and there's a learning curve and getting readjusted, what that is, and it's just like when we do major changes in, Affordable Health Care Act. We have to adjust. We have to figure out what it is. We have to, when things die down and settle down, then you can actually get working. But all that time, other people are doing things, and then freshmen are trying to catch up and figure out what's going on. And it's healthy. It's healthy also. It's a crazy system, but it's the best one we have.
The worst one, except for all of the others, right? Representative Seaton, you had a primary this year as a Republican. Congratulations on winning. What is it like being a Republican in Alaska today, with being on the ballot, with 18 Republicans running for president, now Donald Trump being at a minimum a headline maker, people might say other things as well, and then having 2 U.S. senators that both are willing to condemn his behavior, the only state in the country with 2 U.S. senators that has done that, from 2 Republican U.S. senators. It must make for I don't know, maybe emotional or complicated, or what is it like trying to be a Republican on the ballot in Alaska these days?
Well, it's definitely complicated with that, especially on the national stuff, because although we all have our personal opinions, and those are generally more emotional than technical knowledge. I mean, we really concentrate on the state.
Yeah.
And within our state, there's basically 2 camps. One is we're not going to worry about this fiscal crisis. We're going to wait and see what happens. And then there's the other camp that's saying, this is a crisis, and that's the definition is if we don't do anything, we're going to be out of money in 2 years by the time the next election comes around. And so there's the results of that election is going to determine how the state moves. And there are definitely people in both camps. And so that's going to be a very interesting conversation and result.
Yeah.
So but you have to wait until the end of the election to find out who people send back. That and campaigns make a difference. When people are out campaigning, they should be out saying no taxes, nobody should pay for anything. Everybody should be able to live in Alaska without paying the state government for anything. And there are people that are saying that. And then there's other people that are saying, we need a fiscal plan that'll be sustainable over time and that can solve those kind of problems. But I think with healthcare, with the reforms that we did last time, I agree with David that what we need to do is let those settle, let those go into effect, let some of those things percolate. I mean, there's a few other things we're going to do, but not major. We also, I don't think we did nothing this last time. We also did major, the largest criminal justice reform we've ever had. And so those are 2 big accomplishments for a legislature. The only problem is that our biggest problem, the fiscal gap, we didn't solve. We didn't make any headway at all. And so it's not that we didn't do anything, but we didn't address our biggest problem.
So this may be a politically technical question, but I think it will color the headlines that we'll all see in the next legislative session. If the election is November 8th, does the gubernatorial election start November 9th? And specifically, do you think that there will be Republicans in the legislature that look to the next gubernatorial election and an opportunity perhaps to take on Governor Walker that will stymie some of this potential progress on the fiscal situation? Or do you think that once we get past the election, the caucuses will come together and with the governor and figure out a pathway forward.
Let me correct something. The gubernatorial election for 2 years started 2 years ago.
Yeah,
Right.
that's right. Yeah, and
Well said.
you know, the thing is that some people that would want to run for governor would be looking at that and saying, I'm going to get that problem solved. I don't want to become elected 2 years from now and have no money in CDR and way less money in the earnings of the permanent fund, have no flexibility for solving the problem. But you know, you can never tell what people are thinking. Some people might be thinking that they would like to have that big problem facing them.
Yeah.
So wouldn't be my choice.
Are you running for governor?
No.
Can I make a comment?
Yes,
Yeah,
please.
just a couple comments. One, you know, on this issue of change in government in Alaska, and you know, we're so fortunate to have a volunteer citizen legislature, and also all of us knowing, you know, our representatives. But one of the things that I think has been important in healthcare, because healthcare goes, no matter who's in power, we need a solid set of policies, is that we need to invest in our expertise in our departments, and also actually in the legislature. You know, we really, when we have a staff that are able to commit over a long term, we've seen that in the finance area where we have a couple of staff in the legislature who really move because of their expertise from one office to another. And we've had that certainly developing in some of the offices. That makes a huge difference because the capacity in a very short session for legislators to handle these very complicated issues is pretty difficult. The bandwidth is very slim. So sometimes they cut back on their own resources when really they need more resources to get savings and get things done. And then the other thing I want to tell you that I was thinking about, you asked me the other day, is healthcare's house on fire? And I was thinking, well, you know, the whole state is like the London fire. I mean, we are really, healthcare just fits within this big economic picture that we're facing. And I think there's uncertainty of investment, you know, uncertainty of, you know, what kind of service cutbacks are we going to have to make? We sign contracts with physicians. Are we going to be able to honor those? You know, there's a lot of decision making that's being put off or going on that is not healthy for future either innovation, the kind of innovation that both our legislators have said they want. You know, it's hard to invest in a new care model when you don't know if you can make that commitment financially as a healthcare system.
Yeah.
So I think that healthcare is being hugely affected by a lack of action on our fiscal plan.
I'm going to let that be the last word. Karen Perdue, former commissioner, former Ashland CEO, Fairbanks community leader, Representative Seaton from Homer, chair of the House Committee on Health and Social Services, and Representative David Guttenberg from Fairbanks, member of the House Finance Committee. Thank you all for being here. Let's give them a round of applause. Thank you.